All right, so welcome everyone to our lead poisoning prevention webinar titled Why Children Ages 0 to 5 Are at the Highest Risk for Lead Poisoning and Tips for Mitigating Effects After Exposure. Next slide. So this presentation was developed in collaboration with ICAAP and the Chicago Department of Public Health, and also Reach Out and Read Illinois, which we'll hear a little bit about in a few slides. We do have some upcoming webinars. So we actually just set the date for this Preventing Lead Exposure During Pregnancy and Breastfeeding one today, so that the slides that get sent out afterwards will have the new date of September 1st from 12 to 1. And then later in September, date is TBD still. We're going to talk about after an elevated blood level diagnosis, steps for families, and CDPH case management. So what happens after the test? All right, next slide. So this webinar is CME accredited for 1 credit. This is that statement, and anybody that was involved in the planning or presenting of the webinar, and there were no relevant financial relationships disclosed. Next slide. After the webinar, you will get a PDF of the slides as well as a recording and a link to an evaluation. And to receive the CME or CE credit, you do have to complete that evaluation, and then the certificate will be sent to your email afterwards. Next slide. All right, with that, I'm going to turn it over to our lead project leader, Dr. Stacy Laurent, to give a quick overview of the lead project and reach out and read before turning it over to our speaker today.
Great, thanks, Abby. So I am going to, as Abby said, do a brief overview of this as we go into the next content. So go to the next slide. So we're all here because we know that lead has negative effects. I think the hardest part about lead and the outcomes is that there's usually no symptoms when someone's been exposed to lead or has an elevated lead level. However, we know that throughout the body there is an effect from lead. And so I won't go through each of the systems here, but I think it's really important to know that because we can't see it, it doesn't mean that there's something not happening. And the ones that we focus on a lot and have a lot to do with what we're talking about today are really looking at, the neurologic and cognitive effects of lead exposure, We know that it can affect cognition, decreased IQ, and can affect school performance, in terms of if there's lead poisoning, you can get encephalopathy if the lead levels were extremely high. And we also know that there have been a number of studies looking at these effects, and one in particular looks at ADHD, and it found that even at lead levels of just 5 to 10 micrograms per deciliter, boys were seen to have a 2.5 times more likely risk of having ADHD. And so, as we're going to continue to review, the lower lead levels are also really negative. And so I think that's a big part of what we're really trying to focus on, is that there's really no safe lead level. I can go to the next slide. So what level are we concerned about? As I alluded to, any detectable lead level is something that we want to think about, and really understand that the historical context of this has really changed, and so you can see, in the 70s, we were tolerating lead levels up to 40 before there was any sort of intervention. And then eventually the CDC adopted a level of concern, The language around that has kind of changed, And in 2012, the CDC has really started looking at this and saying that there really is no safe lead level in terms of lead exposure, And so then rather than level of concern, we moved to talking about, the blood lead reference value. You can see, I would say really over the last probably 10 years, there's been a lot of movement in terms of really, really lowering what our threshold is for intervention. And these numbers are really based on this NHANES data. I always feel like talking about this feels like a mouthful, but really what we're trying to do is capture right, the children at the highest risk. And as we've taken care, right, we are making positive gains in lead, even though we're here to talk about the negative effects, but we're making positive gains. So you're left with this top 2.5% of children. And in that percentile, we're looking at for lead levels that are 3.5 or higher, right? So what that means is the majority of children aren't having those, but we're lowering it and lowering it so we can continue to reach those kids who have the highest risk of lead exposure. So here in Illinois, in January of last year, so in 2025, we moved to match the CDC's lead level intervention. So 3.5 deciliters or higher, micrograms per deciliter or higher for public health intervention. Okay, go next. So, right, what do we do about this? Like I said, I don't think it's all bad, right? We're making positive gains, so we still have a lot of work to do and a lot of support that we can do for patients and families. And so, what can we do to really, work through these negative effects and support families? And so, one area is through nutrition, right? So, especially when the body is low in iron, the body is going to see lead as something that it can use to replace that, and so the body's more likely to absorb lead. So we want to make sure that our patients are getting enough iron, and then same with calcium and vitamin C. Again, they're working to improve the body's absorption of iron, of the good things, right, and to stop the body from looking for something else. And so focusing on nutrition, a well-balanced diet is a great place to start for children. Another aspect of this is early intervention. So an elevated blood lead level automatically qualifies children who are in the appropriate age range, which you'll hear a little bit more about later, right? That they are automatically qualified to be enrolled in early intervention, because we know that we really want to work on optimizing their development when we know we have this exposure that can negatively affect them there. And then the other arm of this is thinking about the environment, right? What can we do to create an environment that is, right, not just nurturing, but stimulating, right? We're working on things to positively affect their development. And so when we're looking at this, right, reach out and read, thinking about how do we kind of pair that with our lead poisoning prevention task is, right, you can really think about reach out and read falling in this kind of environment space, right, where it's something that's going to help create this nurturing and stimulating environment. Go next. So what is Reach Out and Read Illinois? I'll talk a little bit about it. Go next one. So it's a lot of words on here, but I wanted it in case people aren't familiar. I think just this slide really captures what we're trying to do with this program, right? So here in Illinois, it enables clinicians who care for children ages birth through 5 to receive a developmentally appropriate book during their well child visits. There has been so much research done on this, right? And Reach Out and Read is a national program, but we're focusing just on how we utilize the program here in Illinois. But what that means is that there's lots and lots of data to support why this is a really important program and how it positively affects our patients and children. And so you can see that the list of things that are helpful are going to be the things that help us mitigate the effects of lead exposure, or just to kind of create environments where, right, maybe those negative effects, if you don't know that it's happening, aren't going to be as severe. And so we know that participation in this program, focusing on reading aloud, right? So this is more than just a free book program, right? We're looking to model how you would utilize a book, how a family can use a book in the home. And so we know that that's been shown to have a positive effect on language development, early brain growth. We know that actually improves getting the children in to see the provider for their well visits, and then really helping with that bond between caregivers and children. So as you can see, right, our program here in Illinois is through the Illinois AAP. And we're reaching so many clinics and so many families. What I think is always startling, which is I think this is a great statistic to think that we're reaching 1 out of every 3 children that could benefit, but also we're only reaching 1 out of every 3 children, right? And so I think it's a program that we're always looking to grow and be able to share more about. The Reach Out and Read Illinois program is really I'm excited to be able to co-host this because I think there's a lot of overlap and a lot of positive movement we can do here. So, great. Go to the next one. So I'm excited to have our presenter with us today. So Dr. Sierra Bauer is a developmental behavioral pediatrician at University of Illinois Chicago, where she's also the program director of their DBP fellowship. And I'm really excited to have her speak on behalf of our programs today.
Thank you, Dr. Laurent, and I'm excited to be here with this group. And so what I want to focus our time on together today is considering risk factors for lead exposure, specifically in children with developmental differences. We're going to talk about a developmental approach to mitigating effects of lead exposure using reading as a paradigm. We're also going to reflect on systemic ways that we can support children and families from a medical, educational, therapeutic, and family support lens, specifically focused on kids with developmental differences who've also experienced lead exposure. So I would be remiss if I didn't start any conversation about children with developmental delays and disabilities without a note on language. And a lot of the way I strive to approach my own practice is encapsulated in this quote by science fiction writer and essayist Ursula K. Le Guin. Words are events. They do things, change things. They transform both speaker and hearer. They feed energy back and forth and amplify it. They feed understanding or emotion back and forth and amplify it. All that to say, some days I'm better at this than others, but I think that when we're talking to families about developmental differences, when we're talking to families about this, how we do it matters because these words stick with them. And it frames how it can influence and frame how they approach their relationship and approach with their children. So in a 2023 study in autism, specifically focused on language in autism, there was a survey of 728 US stakeholders. 87% of autistic adults preferred identity first language, meaning an autistic individual. 13% preferred person first, so that's a person with autism. And professionals, so people like us on this call, potentially preferred person first, consistent with style guidelines for written communication. So this person first language approach was felt almost revolutionary when I was being trained. And so sometimes you'll hear me revert back into it. It's pretty ingrained in me. But when I think about what has changed as autistic self-advocates have gained a stronger voice and a stronger part of community, I think what's been important to recognize that this is their preferred is identity first. And so regardless, right, like as a provider, we're interacting with families. And so sometimes they might not have that same perspective. And so bottom line, it's personal. And I think it's important to be humble, to be respectful, and ask if you're not sure. For the purposes of this talk, when I'm speaking of autistic individuals, I'll use identity first. When I'm speaking of children with developmental delays, I'll do that preferred method, which is more person first. So thinking about this, let's talk about some terms that we're going to be referring to throughout our time together today. So a lot of times we're talking about global developmental delay. And to be sure, I think we're sometimes a little bit more casual in our language with this than we should be. And if we look at criteria, right, kids don't read criteria, people don't read, or people don't follow criteria always, right? But this is kind of a framework from which we can operate. And so when we think about this from the Diagnostic and Statistical Manual, this is a term that is specifically used for children under 5. It involves delays in multiple developmental domains. it requires reassessment over time. It shouldn't be something that's a permanent description. And in the state of Illinois, developmental delay can be used as an eligibility determination, and I would separate that from a diagnosis for an individualized education plan up to 9 years of age. It's not always the same in whatever state you live in. But then what happens, right? So does a person continue with if they don't continue with the diagnosis of global developmental delay, but they're still having significant delays in these areas, we start to think about an intellectual disability. And so I'll be clear, understanding scarce resources and the dearth of developmental specialists, I will not make this diagnosis without psychological and adaptive testing, and we can talk about some of the limitations of that as well. But when we look at this is when there's significant limitations in intellectual functioning, meaning a full-scale IQ, 2 or more standard deviations below the mean. And that has to be on an appropriately normed standardized test of intelligence, and those are administered by psychologists. But then co-occurring with that, it's not just cognition, right? And I think this is where we think about difficulties with adaptive behavior. So adaptive behavior being skills of daily living, skills of independence. Honestly, a lot of the stuff that matters, right? Like as kids get older, and that means a standard also has to be measured on a standardized measure, 2 or more standard deviations below the mean. And so we think about different domains with that, which is conceptual, social, or practical. And I think what's helpful about this is shifting. You'll often see in some IEPs where they might do the standardized measure of adaptive, but they don't necessarily do the score of the standardized test of cognition. I think it's because we're really trying to understand how is this individual functioning in the world that they live. Important as well, this has to occur before the age of 22. So as individuals are developing, I think it's interesting too, right? Because 22 is your 22nd birthday is when you no longer are getting services under an individualized education plan. When we think about the criteria for autism, right, those shifted a lot in 2013. So that is beyond the scope of our discussion today, but when we think about it, there's persistent difficulties in all 3 areas of social communication, 2 of 4 restricted and repetitive behaviors. It affects social emotional reciprocity. We're going to talk about that as it relates to reading, nonverbal communication, and also the ability to develop, maintain, and understand relationships. I think it's important to remember it's not an absence of these skills, it's a difference. And so that is something that's important to remember when we're thinking about the complexity of what autism spectrum condition is and what it means. For the sake of our talk today, when we're thinking about restricted interest and repetitive behaviors, I want you to focus your attention on the bottom, which is a hyper or hypo reactivity to sensory input or unusual sensory interest in the sensory aspects of the environment. This is what I focus on a lot when I'm thinking about lead exposure, right? Because this might be a person who licks, mouths, eats things that are non-edible past the point of when we think that that is developmentally expected. And so that matters. And something that I talk about a decent amount in our clinic. We'll also relate that back to what Dr. Laurent was talking to in relationship to nutrition. Dr. Laurent mentioned a lot of these updates, and I think one of the pieces that I want to emphasize and reiterate is there is no safe lead level. And I would also say what that looks like from a developmental presentation. I can't always correlate the lead level with what I'm seeing from a developmental perspective. So when we think about the lead questionnaire, right? So something that's supposed to be screening at annual well child visits up to the age of 6, there's 2 questions that I focus on when I'm thinking about it, but there's also questions that are not part of this questionnaire. So is the child frequently exposed to imported items? I see this a decent amount when it comes to, it may relate to supplements. It may relate to what's in the home that kids might be mouthing. So it could be pottery, it could be furniture, it could be all sorts of things. I think also living with somebody who has a job or a hobby that may involve lead, but also thinking about what is that child that could be, what are they exposed to in the home that they could be putting in their mouth? But what is not asked on this questionnaire is whether a child is licking, mouthing, or demonstrating oral sensory seeking behaviors past the point we expect. And when I see that, which I see almost daily, it's something that I look back almost immediately, reflexively, to see when the last lead level was checked. So what's my role in this conversation, right? So I love this picture because it's sort of like I think about what we do, and I think about my role over time, it's changed. And when I entered medicine versus today, and I think really how I view my calling is to really walk with families during times of uncertainty and you don't quite know what's around the bend. And I think that that is particularly, I mean, that's life, right? But I think it's also a unique role that we have in medicine and how we support families. And to that end, everybody has a story, right? And these are some common stories that I might see in a day in clinic. So the first one being a 30-month-old presents to clinic with her family. Her family's concerned about speech and behavior. And I'm speaking to an audience, those things go together, right? Like behavior is communication. She has a limited repertoire of tolerated foods. Her family describes that she tends to lick and mouth non-food items. She attends daycare and has not yet been referred to early intervention. I want you to focus specifically on the limited repertoire of tolerated foods and also the oral sensory seeking behaviors. The second, a 3-year, 7-month-old presents with his family for a follow-up visit. He's been discharged from multiple private daycares because of intense tantrums, difficulty calming when upset, aggression toward others. On previous evaluation, he has not met. So the autism diagnostic observation schedule is a tool that we use to look at the DSM-5 criteria of autism, which is why I say that, and pair that with the DSM-5 criteria for autism, and his mother wonders if he has ADHD. A 5-year-old with a history of global developmental delay presents for a follow-up visit. The family describes that he tends to go through phases of oral sensory seeking behaviors, so licking and tasting non-food items. He also has a limited repertoire of foods, and his mother's concerned about nutrition. She recently started supplements she read about on social media. She started them, but she's not quite sure what they are, or she can't remember the name and doesn't have them with her. Just a second. So let's take a step back. So when we're taking a step back, and in my mind, I always think about, especially when we're teaching, right? Like, where are we dwelling and how are we functioning within our clinical guidelines as put forth by the American Academy of Pediatrics? And so as a specialist, I think about what's happened before families have come to me, and I also think about what's going to be happening as that relationship grows over time. So in primary care, you're screening and looking at for neurodevelopmental conditions. You're also screening and providing surveillance for behavioral and emotional differences. So that can happen in the context of that health supervision visit. And then as kids get older, right, you're looking at developmental disabilities, you're looking at vision, you're looking at behavioral emotional problems, all spanning into the bottom line, which is kind of where a lot of the specific conditions that I'm talking to families about. So intellectual and learning disabilities, specific language disorders, autism, motor disorders, and high-risk conditions. Lead exposure is a high-risk condition, right? And I think that also, and I think a theme that I want you to take home today is that overlaps with some of these other developmental conditions. These things aren't mutually exclusive, right? Sometimes we might see an autistic child, and then reflect back and find out that they've later been exposed to lead. Sometimes we might see the lead level first and then find out later that this is more consistent with a developmental delay in autism. So when we're thinking about early brain development, these are some good questions that we've had on our boards, right? So by 3 months of age, your brain is half of half of the adult volume. At 1 year, it's 2/3 of adult size. By 6 years of age, it's 95%. And I think when we think about, and this is some theoretical discussion about how autism spectrum condition occurs, as we think about neurological pruning, right? So refining those connections, allowing synapses to run more efficiently. That's what earlier intervention does, right? So that's what you're doing when you're referring a child for early intervention. You're providing children with positive early experiences. You're contributing to this, right? When we think about synaptic overgrowth, right, that tends to occur between 5 and 6 years of age. That's refined by pruning. So that's refined by the connections that are made early in development, but that also peaks in adolescence and continues into adulthood. So I think about this with some of the conditions that I see co-occurring at preschool age and then also in adolescence. And I think that's an interesting connection when we're thinking about it. So we're going to dig deep here. So going back to some of the theoretical ways that we've thought about development. And so Piaget was one of the ones that talked specifically about a sensory motor stage. I want to preface this by saying that, these theories are theories in and of themselves, right? And I think we can take from them some points, but I'd also acknowledge that it can't be generalized to the population always, and it doesn't account for different sociolinguistic and cultural differences in our population. So I think when I think about that, I also want to make sure that I'm thinking through it through that lens, but also recognizing what might be of value, right? Which is that in infancy, children they learn through their senses. So touch, sight, hearing, mouthing, right? So in relationship to our conversation today, that's where that is relevant. And then thinking about joint attention, which is really what reading is, right? And so I think when we're thinking about mitigating effects of lead exposure, I think reading is a great tool to provide us information, but it's also a great tool to talk about creating those positive connections. So joint attention, for those of you that this might be a new term to, it's when one individual seeks to coordinate another person's attention to an item of interest, right? So there's lots of components to this. There's verbal, there's nonverbal communication, there's gestures, there's facial expressions. It typically involves two or more people paying attention to the same thing, like a book, right? And that usually has intention and is done for a social purpose. It's the foundation for social communication. And remember back to what I was talking about with the diagnostic criteria for autism. To meet those criteria, you have to have differences in 3 different areas of social communication, the foundation of which is joint attention. And so that is an area when we're thinking about how to provide intervention and how to provide systemic support for individuals. That's where a lot of that focus comes into. And sensory regulation. So when I was talking about when some people have different sensory interests, that is also something that can help support joint attention. So when things go differently, right? How does lead participate in this, right? So toxic stress is something that can affect early brain development, right? So think about growth, think about pruning, deprivation, right? So if those relationships, those caregiver-child relationships are not happening the way we hope and expect, that can affect things, right? There's lots of things that we can allude to within deprivation, but I think that's what I'd focus on for today. But then also neurotoxins. So lead is one of those that disrupts early brain development, right? So in the environment, when we think about lead, it's mostly present, and I'm not a biochemist, so I also feel the need to preface that, but in the environment, it's in this ionic state, and I think that matters, right? So Dr. Laurent was alluding to the fact that we can provide nutritional support with calcium, with iron, with a well-balanced diet. Lead substitutes for calcium, right? It crosses the blood-brain barrier. When I'm seeing kids who have a limited repertoire of food, and if I have the luxury of looking at a nutrition evaluation, calcium is often affected, iron is often affected, vitamin D is often affected. So when we think about that ionic state and what's being disrupted, this is all biochemically related, right? So if kids are only eating 2 foods, you're not going to be able to provide a well-balanced diet. And then families are really in a tough spot in terms of supporting them. And I think one of those restricted interests or limited behaviors that can be present for autistic individuals, that can be present for children with developmental differences, nutrition can be very, very difficult. So something to think about. When they've done larger studies looking at nutrition in selective eaters, I think one of the things that they've talked about specifically is some of these micronutrients that are affected. So as much as possible, I try to support families with taking a multivitamin. I think one of the challenges with that is, will they tolerate the multivitamin? Some kids are so sensitive so hypersensitive from an oral standpoint, the vitamin isn't tolerated. And then you sometimes see kids drop different liquids. And so you're worried about hydration. So all that to say, it's not simple, right? And I think everybody on this call probably appreciates that. I think this is the reason why, going back to some of the neuroscience part of it, is that the main target for lead toxicity is the central nervous system. And those actions can involve programmed cell deaths that affects neurotransmitter release and storage. So neurotransmitters, so the messengers throughout the body, right, or throughout the body, but particularly the CNS, it affects the receptor. So receiving that message, and then also thinking about how this could manifest with growth and pruning. So what does that look like, right? We think about decreased IQ. We think about lower academic achievement over time. We think about decreased attention span. We think about sometimes some really significant challenges with behavioral regulation, so hyperactivity, impulsivity. We think about also, I think elopement is something that really impulsive kids do. It tends to peak during the preschool period for autistic individuals, and it's very different than kind of a fight, flight, freeze response. It's really they're running towards something that they're very interested in. And I think that's something that we have to sort of think about too. And we're seeing kids who do that. Again, somebody comes in and this is a new behavior. I go back and I look to see if lead has been checked recently. So just to recap a little bit and recenter ourselves in this part of the talk, I think about if families will often come and talk about sensory symptoms, right? So to me, that means is somebody hyposensitive to something, but I think about how it affects a child on a daily basis, because we all, as humans, have differences in sensory regulation. The question is, how does it affect us and how we function? When I'm seeing this in early development, I think about, is this something that's going to be resolving over time? Is this something that could be associated with autism? Is this something that could be associated with an emotional or behavioral condition such as ADHD? So I think about reasons for those sensory symptoms. And I also think about following kids over time because that changes. I think we've alluded to this. I've talked about this a few times. So I want to move on to what ICAAP is and how that is a particular issue for children with developmental delays and disabilities and autistic children. So the technical definition is that eating non-nutritive, non-food substances over a period of at least 1 month. It has to not be consistent with their developmental age. So notice developmental age, not chronological. Thinking about something that's not necessarily a socially normative or culturally accepted behavior. And so all of these consequences I have seen for kids who eat non-food items, so gastrointestinal parasites, lead toxicity, nutritional deficiencies. I would say lead toxicity, nutritional deficiencies, when I see them, they're usually hand in hand. Foreign body ingestion, choking, and also even most severely intestinal obstruction and perforation. So this is actually a study that was using SEED methodology. So this from 2021. So SEED methodology meaning stakeholders engagement and question development prioritization. So looking at people who this affects, right? So this was something that was done over 6 states. So California, Colorado, Georgia, Maryland, North Carolina, and Pennsylvania. And so they looked at approximately 4,700 kids, 1,400 of whom were autistic, 1,700 of whom had developmental delays and disabilities, and 1,500 without those traits. So when we think about pica in the general population, you'll see prevalence numbers about 3.2 to 3.5%. But look at these, right? So it's so much higher in kids with developmental delays and disabilities. So 23.2% in autistic individuals, 8.4% in kids with developmental disabilities. And then it goes down, right? And sort of separates it with intellectual disability, without intellectual disability. And so then there's also kids who you see who have developmental disabilities with autistic traits, but who do not necessarily meet the diagnostic criteria. And those kids also have a much higher prevalence of 12.0%. So I think the take home from this that I want you to consider is the fact that when you're seeing kids with developmental delays and disabilities, they're at higher risk of pica behavior. They are also at higher risk, therefore, of lead exposure and toxicity. So when you think about what those look like, what I want you to absorb this and sort of put it on a shelf for a couple slides. So we see kids with lead exposure who have developmental delay, learning difficulties, irritability, loss of appetite, weight loss, fatigue, abdominal pain, vomiting, constipation, hearing loss, and seizures. So these are also a similar constellation of co-occurring conditions to something else we're going to talk about, right? So the time course, as Dr. Laurent mentioned earlier, you may not have symptoms, right? They may develop over weeks to months. You might have random flare-ups. But when I'm seeing kids who have behavior change, they might be if we're thinking about lead toxicity as an overlay with that, do they have headaches? Do they have stomach pain? Are they more tired at school? Are you seeing anemia? Are there learning problems? Are they having some GI symptoms such as vomiting? The problem with this, I would say, is that if there's something that's more non-subtle, right? Like a parent or a caregiver it's not going to be subtle if a child's vomiting, right? But I find it hard sometimes for kids to necessarily localize where they're feeling. The kids that I see often have communication difficulties, so being able to share that they have a headache is not something that may be easy to see. So that sometimes can present with fatigue or behavior change. So my point with this is that what it looks like may not be what it is. And so when you see behavior changes, you have to look a little bit deeper. So as I mentioned, so those symptoms that we were talking about earlier of lead toxicity, those are often similar to co-occurring conditions that we often talk about in developmental follow-up. So seizures, feeding difficulties, remember that limited repertoire of food I was talking about. Kids who have difficulty with emotional and behavioral regulation, motor disorders, GI differences, learning differences, speech and language disorders, sleep. Sleep is big, right? If sleep is disrupted, almost often behavior is also disrupted during the day, and kids might be having difficulty paying attention, right? So there's overlay and complexity here that I think what I would encourage you to do is when you're concerned, dig a little bit deeper. Families are often in a position, I would say, of playing detective, right? For the kids I see, I think parents in general, right, are playing detective a lot of times, like what's really going on here. But when kids can't always tell you what they're feeling, they can't necessarily tell you where it hurts. I think we have to think a little bit more deliberately about this and recognizing that the co-occurring conditions that are higher in kids with developmental differences overlap with the symptoms of lead exposure and toxicity. I think I've brought this point home. Behavior is communication. And so when we think about that, how do we think about behavior and communication and ways to support families and really think about how kids respond to books and reading together? What information does that give us, and how can we support families in that process? Reach Out and Read being an incredible program that does that. So in 2022, the developmental milestones were revised. Within that, what they did was that for a milestone to be given an age, 75% of kids have to meet that milestone. And by doing that, the idea is that we stop a watch and wait approach. So we're referring kids earlier when we're concerned. We're getting more sets of eyes on them in terms of supporting them and providing information about how they're developing. Reading is so much a part of these milestones. So when we're thinking about a social emotional milestone, first at 18 months, will a child look at a few pages of a book with a caregiver? That's something that's specifically screened on the ASQSE. From a cognitive perspective, is a child able to tell what comes next in the story? That tends to happen at 4, right? So that's also, I think, gives you an idea of where their language is. From a motor standpoint, turning pages of a book one at a time when you read to them. That happens for 75% of kids at 30 months. And where that's measured, you can ask that, but that's also something that's measured on the Mullen Scales of Early Learning, which is a study that's often used in autism studies, or a cognitive measure that's developmental measure that's often used in autism studies. Language and communication is where a lot of these book milestones are. So first at 24 months, pointing to things in a book and asking, where is the bear? That's measured on the ASQ3. Naming something when you ask, what's this? 30 months. That's the ASQ, but also the Bailey, which is also a developmental measure. Often we see that sometimes in our developmental clinics, but also sometimes NICU follow-up. What's happening in a picture, right? So running, eating, action words, right? That tends to happen around 3 years of age for 75% of kids. And those are the measures, the ASQ and the Bailey, by which those are specifically asked. So at 4 years, kids should be saying some words from a song or a nursery rhyme. At 5 years, they should be answering simple questions about a book or a story after you read it to tell it to them. So I think the point that I want you to take about this is books give us a lot of information, but to read a book with a child, that's not always an easy thing to do. And so sometimes I'll ask families, just starting with, and are you able to read a book with your child? And oftentimes in our clinics, that may not be the case. And they're like, it's really, really hard. Like it's hard for them to sit, it's hard for them to attend. And then I'll ask them why, right? It could be that that's not, it's hard to get their attention, it's hard to sustain their attention. And that gives us information back to what we were talking about. Reading a book together is an activity of joint attention that can give us information about what's going on. And after I hear that, I might dig a little deeper and find out about some of those sensory symptoms that might be challenging. So let's go back to those stories that I was talking about. So a typical day where I'm seeing a 30-month-old whose parents are concerned about speech and behavior, a limited repertoire of foods, and also some oral sensory seeking behaviors. I'm going to take a step back. And in that situation, I'm going to look at nutrition. I'm going to look at lead levels. I'm going to look at a hearing test. I'm also going to talk to the family about engaging in early intervention. A 3 or 7-month-old who's presenting for follow-up and the family's concerned about ADHD. A discussion about preschool ADHD is beyond our scope today, but what I would tell you is that this is not an uncommon story that families will share, right? That they're having trouble keeping their kids in daycare because of a lot of hyperactivity, a lot of behavioral challenge. And so in that situation, what I would start with is talking to the family about enrollment in a school district program where we could get them more structured support. I'd also be talking to them about what's going on from a home standpoint to see if we could get them some support for their behavior. A 5-year-old with a history of global developmental delay who has oral sensory seeking behaviors and also a limited repertoire of foods. So I think the reason I tell the story this way and with this age is because this might be a new thing. So sometimes families will share that this is new. All of a sudden they're licking and tasting things that they weren't before. Again, I go back, I look at when their last lead level was checked. I might call their pediatrician in that situation. We talk about nutrition. And also, I think that supporting families with understanding that they are not the only, this might be beyond what we talk about in terms of selective eating with kids. I think it's not just giving them, you have to give them options, but we have to talk about access to options and sort of how we can support them with that as well. So what are next best steps? I love this slide because I think it sort of encapsulates, I should say, what we hear about from families, right? Is that sometimes they're trying to figure out what direction to go and they run into dead ends and obstacles often in accessing the resources that I just shared, right? And so when I think about that, I think about how can I support them with sort of backing up and getting back on track in that situation and being a source of support. It's not easy, right? And I think that in general, right, or when we look at national data, there's a approximately 800 board certified developmental behavioral pediatricians and an estimated, I might be off here, so don't quote me, but 19 million kids who've been identified with developmental delays and disabilities. And so when I hear that number, after I sort of get over the overwhelm of that, I think what I realize from a practical standpoint that in my lifetime, there are not going to be enough developmental pediatricians to meet the need of the kids that need them. And to that end, I think it would be great if every child who has lead exposure would be seen by a developmental pediatrician. But my concern with that is it's not accessible to the kids who need it most. So then how do we make sure that the message is out there in terms of supporting providers, educators, families, accessing those systemic resources that we have to make sure that they're getting the help they need? And I think from a system standpoint, I think about medical interventions, I think about educational, therapeutic, and family support. And in general, right, like when as an educator, as a therapist, as a physician, a provider, I think it's important to think about when challenging behaviors develop or change from baseline, right? That can cue you in that something else could be going on. So I think it's important in the kids that who are having that to maintain a low index of suspicion for lead exposure in kids who have sensory seeking behaviors and developmental differences. When that happens, I also, when I'm thinking about it, I go from top to bottom with a review of systems, right? Like have you noticed a change in this area? Is there a change in anything going on with their skin that could be happening? Like looking for a medical reason first to explain a behavior change, with lead being part of that conversation. Addressing those first, and then once that's addressed, you can start thinking about systemic approaches to connecting children and families. And then after the system piece is addressed, if it's available, starting to think about individualized options for the family and following them over time. So one of those, and Dr. Laurent mentioned it, right? Like if you have a lead level of greater than or equal to 3.5 micrograms per deciliter, you automatically qualify for early intervention, right? And so early intervention is separated into it's separated into different areas called Child and Family Connections offices, right? This is the state of Illinois and what that looks like. There's multiple zip codes that are a part of that conversation in the Chicago Cook County area. So when I'm referring families to that system, it's not just call early intervention. It's not just me sending in a referral. The system is big, right? And there's a lot of people who are trying to access it. Again, there's not enough providers. So empowering families on how to advocate for that, I think, is important. So not only giving them the number of their local CFC, but then also talking to them about if you haven't heard back within 2 business days, you need to call again. And if you're still having trouble, then I think asking to talk, you getting involved as a provider or an educator, I think is important. So then what about the kids who are 34 months old that you're seeing? Maybe it shows up in acute care visit. Maybe it shows up in a different possibility that they is it too late to access early intervention? I think that for kids who are in it, right, EI should be helping them with the transition to the school district. That participation is voluntary. Families don't have to do it, right? It should happen about 90 days, at least 90 days prior to a child's 3rd birthday. And then from that, their individualized family service plan that's part of early intervention becomes an individualized education plan through the school district. If families have not been able to access early intervention, as I mentioned a couple paragraphs ago, I think bringing the conversation and talking to their local school district, right? They need to be referred to them in the Chicagoland area. It often involves showing them where the CPS child find screenings are happening, finding the library or the center that's closest to them, looking at the dates that those screens are offered, and then talking to them about what transportation is required, what work excuse might be required for them to get to that. It's a lot, right? So I think that sort of That I feel like sometimes is the level of support that we need to think about as we're supporting families. There are resources to support families in terms of accessing these resources. Within the state of Illinois, Family Matters Parent Training Information is one that can help with school district and navigating those things. For parent coaching and support with behavioral regulation, the Beacon portal is a centralized resource in the state of Illinois that can be helpful and something that I encourage families to register for. If there are folks from that here, I would love to hear about your perspective. So I think when we're thinking about it, right, I think about what are the systems that we have? What are the ones that I think would be helpful for kids and families if they're going through sort of, if they have a history of lead exposure or toxicity, if we're seeing kids with developmental differences, this is how I think about it. As a healthcare provider or a school-based provider, if you're struggling with resources, another one to consider is Illinois Doc Assist. And so they also provide no-cost support to us. I call them in terms of trying to figure out what's a resource. Am I missing something? Do I need to think about something else? So as we think about what we talked about today, first and foremost, I think reading together gives us a lot of information. It tells us about caregiver-children relationships. It tells us about kids' strengths, interests, and abilities. Not being able to participate in that or that being a challenging experience also tells us something, right? And then if you follow that a few steps down, I think there can be an intersection absolutely with what's going on with lead exposure and toxicity. Pica behavior has a higher prevalence in autistic children and children with developmental delays and disabilities. And lead exposure, lead toxicity is one of those potential consequences. So if behavior changes from baseline or it becomes more challenging to regulate, going through a review of systems to see if there's something else going on, I think is the first step. And then afterwards, utilizing a proactive and systemic approach to supporting kids in that process. So thank you for your time.
Thank you, Dr. Bauer. I put in the chat that if anyone has questions, please add them to the Q&A box. I don't see any right now, but we'll give it a minute or so. So yeah, if you have questions for Dr. Bauer, Dr. Laurent about the Reach Out and Read program, you have plenty of people here to answer whatever questions you have. And I'll go ahead and stop recording as well.